Well, welcome everybody to the ICMDA webinars for this afternoon. And today's topic is COVID and its likely impact on the future of healthcare. And we're delighted to have my predecessor at ICMDA, Dr. Vinod Shah and Arun Zechariah leading today. I'm Dr. Peter Saunders, the CEO of ICMDA, which makes up over 80 national associations of doctors and dentists throughout the world. So it's now my pleasure to introduce Vinod and Arun. Vinod Shah was born in 1947. He did his MBBS and Master in Surgery from Christian Medical College in Vellore, India, and he has a passion for serving God through medical mission. He came to Christian faith from a Jain background in India. He served as executive director of the Emmanuel Hospital Association in New Delhi for some years, and then after that set up the distance education department at CMC Vellore, which is still running and doing great things. And then after that, for 8 years, he was the CEO of ICMDA before going back into surgery and developing these movements of the future that he's going to be talking to us about today. He's married to Shalini and they have 3 children. And then our second speaker is Arun Zechariah, who is an IT consultant also at the Christian Medical College, Vellore in India. He received his MS in software engineering in Michigan, USA, and he worked in the corporate world for 20 years before he and his family returned to India in obedience to God's call. In fact, Arun's wife, Rebecca, is currently leading at the distance education unit at Vellore. So Arun has experience with the banking industry, which is now being used in education technology, and he's developed a strong interest in building cost-effective online platforms for medical education. So it's a great privilege for us today to have Vinod Shah and Arun Zechariah speaking to us. Over to you.
Thank you for that introduction, Peter. It's wonderful to talk to you, ICMDA folk, after more than a year. This particular topic was not really all guesswork. Even as we are talking, these changes are rapidly happening in our country and in other countries. The only question would be whether these changes would be permanent or would they go back after COVID has been sort of conquered. Next slide, please. There are 4 major areas of impact that we are going to talk about. The first one is on medical education. And then it's on patient management, and then how will COVID affect healthcare delivery mechanisms is actually a big topic, and then some impact on healthcare training and healthcare cadres. And so we start off with medical education, and Arun will take us through this particular aspect.
Thank you. So we spent some time thinking of the various trends that are happening in education. Some of them have started already, and some of them have risen dramatically due to the pandemic situation and the need for less travel and also the need for being distance. And some of them are virtual classrooms, and then additionally having one classroom in many locations. Added to that, there is also this trend of decreasing costs because of cloud services and being able to use a pay-as-you-go model. Earlier, we'd have to invest a lot in infrastructure to carry out some of the distance education or online education, but that is no longer the case. You can start with a low-cost model. And then the other thing that has been there for a while, but has taken more precedence now is the blended learning model, that we will talk about a little bit. So COVID-19, you might have noticed, and in your families, in your circle, it has accelerated the use of technology. In my nephews, they're only in elementary school, but even they have online classes. So primary schools to medical schools are leveraging the technology that is available. And for the higher education, video lectures, self-learning modules, which are standalone modules which interact with the student and help them not just click and listen to a video, but ask questions in the middle and help them branch, do assessments and do evaluations to help them proceed, are already available. And there's a concept of flipped classroom where professors and teachers are providing lectures, modules, recommended readings, and then coming together online or in a physical classroom to explain those four. Additionally, technology in the animation industry has been used to simplify earlier topics that were very complex for science and for medicine. Things like the rotation of the gut or the route of the spinothalamic tract. Now, we've seen some of the doctors who were not exposed to such technology. When they saw the animation and the videos the first time around, they were quite in awe, and they really wished if they could have something like this. So it has done that very much so. And now it's a possibility and already happening where you could have one virtual classroom and many medical schools or many medical students connect from different locations in either in a physical medical school or online and learn together. Professors and educators have taken time to create better exams and evaluations, which are objective but are no less important than the older methodologies that we have, and actually test the students and assess them better. And there is now available skills and laboratory simulation technology, which reduces the need for simulated patients or real patients. It doesn't take away completely, but it reduces, it helps the student try again and again without having to cause harm or that. And one of the outcomes of this might be there'll be a less hospital dependency for medical education. They could do a lot of the simulations and laboratory skills online and otherwise, and then come together for a contact program as such. Here's some of the equipment that is available. Some of you might already have it. Some of the low resource settings, these are not available yet. But here at CMC Velo, we use it in a distance education platform when students do come in for a contact program. The other main concept or idea is the access to these and the cost has drastically reduced. And in a way, we can use the word democratization of education, access for all. And many of you might have already noticed, if you wanted to find something, you can find solid information online. You might have to search through and glean through it, but you can find that. So one of the fallouts of that, or a possible natural progression, would be you would only need a small group of expert medical teachers who can potentially produce all the learning material needed for a whole nation. And more, education is going the route where you are guided by the side rather than the sage from the stage. The older methodologies, you'd have a expert, a scholar standing up on stage and giving a lecture, and where you all took furious notes, and if you missed something, you lost it. It has changed from that to more a guide by the side, either in person or online, where the role is more of a facilitator, especially for adult learners, rather than just a sage from the stage. And like I mentioned earlier, these cloud-based web services have become less and less expensive and accessible. I remember in my early days of work, it would literally require hundreds of thousands of dollars to put together a data center where we could have a few hundred people connect at a time. But now with the credit card and a few clicks of the button, you could have a server running in the cloud in a matter of 20 minutes. And the best part is if you don't like it after 20 minutes, you turn it off and it doesn't cost you much at all. So that is another huge progression that has happened in the last decade and more. And so if somebody would want to use it, they would. All of these would really have an impact on medical education. Additionally, doctor nurses shortages are there, and if medical is becoming very expensive, by using some of these which are trends that are already in place on improving on them, the poorer part of society might be able to better afford medical education. And actually, if there's intention, if the rules and the governments set up the official certifications and all of that, the shortages of professionals in rural areas would be a thing of the past. Just today in India, the newspaper, the UGC, which is the University Grants Commission, they just put out a notice saying that they will be ready to certify blended education. The modalities are still not clear, but that's a big, big difference. And like Dr. Shah mentioned, it's still to be seen if this is for the pandemic situation or this is here to stay, but these changes are certainly happening as we speak. Lastly, I want to just spend a little bit of time on the blended learning approach, which is, I would consider, one of the advances in education technology. It's essentially a hybrid learning program where I think it takes the best of both worlds, where you could have a self-directed learning, which is typically online or through books and material that are shared beforehand, in a combination with face-to-face interaction with peers and instructors, either as a physical contact program at one of our mission hospitals or one of our organization centers, or online where they may have a discussion forum in small groups and so on. So these are the few thoughts I wanted to leave about medical education. Along with that, just wanted to provide a quick listing for those who are interested, and we will share the slides later. But if you think about what's needed, you need content creation, delivery, and then you need management and administration of it. There are several software tools that are already available. Many of them are open source and free. Open source means you don't pay for the program, but you do still have to pay for hosting it or running it on a server. And I just wanted to leave you with some of the different tool sets that we are already using here at CMC and also at ICMDA for our learning platform. We're already using some of these tools. As a side to this, one of the cons would probably be the mental health, and then Dr. Shah will take us through the next few slides.
Thank you, Arun. We go on to the next slide about mental illness. There are unverified reports that mental illness in India among medical students is actually increasing, and number of suicides are increasing. And this might be a trend all over the world. Some reasons are that doing work online all the time and being addicted to technology prevents you from face-to-face interaction. And when you don't have face-to-face interaction, it produces what this author calls loneliness. And loneliness produces a whole gamut of diseases and disorders. If you're lonely, you're more likely to need a geriatric home. That means your disability will be very great. If you're lonely, you are not likely to exercise. You're more likely to be obese. You're more likely to need serious operations and have hormonal problems. Next slide. You're a greater risk of contracting infections. Your memory may be worse. you're more likely to be depressed, to sleep badly, and to suffer dementia and general cognitive decline. Next. And so this is one of the possible impacts of uh, online education, especially when that person is also otherwise addicted to, watching movies all the time on Netflix and doing things always on the phone or the computer, and does not sort of seek out face-to-face relationships. Next.
Yeah. Thank you, sir, for that. And that is one of the possible drawbacks. We see lot of pros with moving with online blended education and virtual classrooms. This might be something that we might have to balance out. And especially for the medical education, the physical interaction will never go away. It should always be there. But how can we optimally use the technologies available in a cost, also for cost effectiveness is an important one. The next part we wanted to talk about is the impact that COVID and technology would have on patient management. And we've been seeing more and more now with different technologies available. They're able to augment clinical medicine, and actually reduce the patient-doctor interface time. Will be actually be reduced. We've already had this anecdotally in India and elsewhere where patients are calling their doctors on the phone, and in India, WhatsApp's a big thing. You're calling on WhatsApp and all of that. So some of the things that are bound to happen is that patient-doctor interface will reduce. And there's a lot of imaging technology that is available and miniaturized. We all know of ultrasound, MRI, and even now thermal scans are being used with artificial intelligence to help augment clinical medicine. An example is in India, we've actually bought 100 robotic surgeons, and a priority which can be concerned, which can be questioned really, is do we have that time and money to spend on that in a place like India where we need better healthcare and costs are rising every day. Robotic surgery is something that's already available not just in Western countries but also in India. The advantages are some of the rural patients may not need to travel as far for it, but on the other hand, there may be other issues with that. Additionally, the software skills, the software-wise technology can be used to reduce in-hospital wandering time, especially in a country like India where there isn't a proper workflow. Many changes have happened now. Patients can register online. They can make appointments online. They even take a history sheet for themselves online. And then they visit the doctor in the hospital or via telehealth. Additionally, a lot of progress has been made for decision trees and artificial intelligence, not to replace the doctor's know-how or the expertise, but to augment. And in a place like India, where a doctor might easily see tens of patients in an hour, this goes a long way in helping them remember and not forget certain things, and helping them through go through a checklist. Now, where this can reduce is not only reduce the number of doctors needed in a particular area, but might also reduce the load on the doctors, physical load on the doctors. And by breaking the workflow into smaller tasks and using technology, there increasingly specific tasks can be delegated to technicians. So we can see a point where just a health worker could be the one initially meeting the patient and helping them through the history sheet before even the nurse or the doctor themselves visit with the patient. Lot of open source material is already available. OpenMRS, which is been around for over a decade now, used in several countries. For imaging technology, DCM for Shea, again, is open source. We do use it here in CMC as a addition to proprietary software that we have bought. And then there's symptom checkers like Isabel and a few others that are coming on, and EMR and EHR acceptance is growing even in a rural place. And now with the advancement of smart devices, EMR, EHRs are becoming very common, not just to help the health workers, but also to keep in touch with the patients themselves. Next, we wanted to spend some time on the impact on healthcare delivery, and Dr. Shah will take us through the first one here.
Yes, thank you, Arun. One of the big impacts of COVID would be precipitating home-based care. Home-based care was already happening before the COVID epidemic, simply because it was much cheaper, and because costs of healthcare have gone up so much that even middle-class people are unable to afford it. And so it was already beginning, but what has happened because of COVID is these companies have invested a lot of money and they're scaling up home-based care operations. One company recently invested some 80 million US dollars starting home-based care. Today, I heard that a lot of the hospitals are started home-based COVID program for some $10 a day. So things are moving in that particular direction. It is especially useful for the older and the infirm patients who have risk of COVID infections, because you don't want to come to a hospital where you get a lot of patients with all kinds of infections. You can be in your home where only 1 or 2 health workers will come and see you. It is also very good for caregivers because, parents or children often don't have time to take children or old people to the hospital. But they would be very happy if the caregiver comes to the home. They would have time to be at home at a particular time, and they will not find it all that difficult. And then patients who are required to visit hospitals repeatedly, all chronic illnesses, which is actually the bulk of diseases today, diabetes, hypertension, stroke, and all the geriatric issues, all of that require patients to visit hospitals quite often. And a lot of that can be done now at home, preventing them from actually visiting hospitals. Now, here's a list of the things that a home-based care person do. This list is actually increasing by the day because people are creating more and more gadgets that make it easy for people to do things at home. A home-based care worker, if you train them appropriately, can take a history and do a physical examination of a patient. He will be helped by the use of a decision tree. A decision tree is something that is a software where you click the symptoms: cough, 2 months, no blood, mucus present, and stuff like that. You keep on pressing all the symptoms, and then you put in all the physical findings, and then it gives you 2 or 3 diagnoses. I have prepared a software, a decision tree. It is not complete, but that sort of thing will help home caregivers to do a good history and a reasonably good physical examination. And then they can collect blood, they can do dressings, and this is very, very important because very large numbers of diabetics have foot ulcers. I think in India, every other house will have a patient with a foot ulcer or some problem requiring a dressing. And a lot of people now requiring physiotherapy, changing feeding tubes, changing catheters, um, educating family members and empowering the family to actually look after the old person rather than being too dependent on a health worker. And also, especially for us, providing spiritual counsel and prayer support would be definitely extremely helpful for home-based care. Now, we are developing a home-based care company simply because we want to have this Christian counsel and prayer as an important strategy for the country. Next slide. Now, what are the advantages of home-based care? One is it is less expensive. It is less expensive because the most expensive part of hospitalization is actually the hospital bed. But if a patient is at home, he doesn't really have to pay for a hospital bed. He needs to pay only for investigations and for drugs and for the visit of the healthcare worker. And also it will spare him the waiting period. In India, patients have to wait a great deal. In Vellore, for example, they have to wait almost 4, 6, 8 hours before they get seen. And then another big advantage of home-based care is when a home-based care worker goes to the home, and if he finds that a family physician that the home-based care worker is connected with cannot actually help this patient, that person can connect him to a specialist anywhere in the world. So it may be possible for a telehealth Christian network of physicians to connect, to become one registry and provide care all over the world and provide prayer support and stuff like that. And finally, home-based care is slowly getting integrated with hospital care. And the driver for this are the insurance companies. The insurance companies have found that paying for home-based care is much cheaper than paying for hospitalization. Even if a patient gets daycare surgery where he stays in the hospital for maybe only a day, still the hospital bills become very large. And so the insurance companies are supporting home-based care. And because of that, the integration of home-based care to hospitalized care will be much faster. And then the hospitals will get centrifuged. That means we don't want a hospital where 5,000 people come to one building. That sort of crowd will actually only increase infection. And so you want to decentralize the hospital. And so you might find that you might not have one big hospital, you may have several small hospitals. And those several small hospitals through which home-based care can be provided. So you might see these big, massive hospital buildings get different places. Next.
So the other healthcare delivery change, what we've been discussing, is from home-based care, and the other thing that's coming up really rapidly is telehealth. And telehealth technicians enabled with patient consultation, with a possible global panel of physicians, can have a big impact. And several organizations in India have already started that. And one of the thoughts around this is to create a panel of Christian physicians around the world to provide teleconsultation. And at the early stages, it's happening with a few people that we already know from North America and North Africa and India and China. But there is a real potential there. A family care physician or a primary care physician working along with telehealth physicians all over the world will be really empowered. And all around, it will be a very financially sustainable item to take on, because the cost will not be great, but the needs they meet and the services they provide will greatly outweigh how much it's going to cost to do that. In India alone, the number of healthcare professionals is requirement is just growing. There's just a quick slide to show what is just the need in India. But this is only for the government sector. And if you look at it, almost 30,000 doctors are required at our primary healthcare centers. Almost 44,000 nurses and midwives are needed. So this situation, the pandemic and all the other changes, is going to have a big impact on the healthcare cadre workers. So there'll be different alternative healthcare professionals that will be growing.
Okay. Finally, I just want us to look at the opportunities we have. We've already mentioned about a telehealth network. We've already mentioned about home-based care and how it gives you an opportunity to actually increase relationship with the patient and to be able to witness to them in a very appropriate way. I believe that witnessing in a home-based care situation is more appropriate because you are more vulnerable in the home. In the hospital, the doctor is very powerful. And when the powerful speak, it can often be seen as a coercion. That's why you're not supposed to use your power to be able to, witness, according to some people. But in a home, you're not powerful, you're actually vulnerable. And so your witnessing becomes more appropriate and actually more meaningful. And then finally, the opportunity for training healthcare workers. The demand for healthcare workers is going to increase greatly because of several reasons. One is there is an increased demand for health because of the opportunities of new discoveries, new gadgets, and new knowledge. People are wanting more and more healthcare. And so there's going to be a great demand for healthcare. Secondly, the healthcare related industry, the pharmaceutical companies and the companies that make equipment and gadgets, they're all very aggressively promoting their products with results that it will increase consumption. And finally, the world actually is aging, most of the world. That means the demand for healthcare is increasing. The demand for healthcare increases with age. And people in the geriatric age group consume maybe 50% of the healthcare. And, from youth to 60, you hardly actually consume so much health. And so because the world is aging, the consumption of health is actually also going to increase greatly. And therefore, the demand for human resources is going to increase a lot. And it will be important for us to train a lot of Christian young people, because this is an area where you can make a Christian impact. So these are some opportunities for us. And so I just want to round up. We talked about medical education and how it is going to go online, how it can be a challenge for keeping your sanity for medical students doing online work all the time. We talked about how patient management is going to change. There is going to be more technology interface. The more direct patient-doctor interface may reduce. And then we talked about healthcare delivery mechanisms. We talked about home-based care. We talked about telehealth. And finally, we talked about the need for great numbers of healthcare workers. Thank you so much. Peter, I think we are done.
Thank you so much.
Thank you very much, Vinod and Arun. If you could just take your slides off the screen now, and we'll move into a time of questions. Firstly, perhaps a question to you, Vinod. What are some ways in which we can ensure the integrity of online testing so that it is not just open book? You know, the idea of the whole family all taking part in the exam with things that they can draw on. So how do we assure that online testing is both objective and fair, but also that there's no opportunity for cheating?
Yes, thank you for that question, Peter. There has been a lot of sophistication in the evaluation, methods of evaluation online. You know, in the olden days, we just had objective type questions. But now you can have different kinds of questions. You can have key feature questions. You can have, I've forgotten the names now. It's a long time ago when I did this, but you can have a case scenario, and then you can post questions saying, can you arrange in the order of priority the things that you would do? And then you give a list of 20 things, and then they have to arrange in order of priority those things you would do to this particular patient whose case history has been given. So there is a lot of sophistication in the evaluation technique. It is always easier to do objective evaluation in online learning because you can just get a computer to do that wholesale. But if you write essays, it requires a person to read the essays, and then it becomes extremely subjective. So gone are the days when you can say, draw a diagram of the knee joint and label, or draw or write an essay on the functions of the liver. You know, those questions are not going to happen because they are very subjective in the way you can assess them.
If I may add on to, there is formative and summative assessment. So essentially the final exam is not the all that there is to it. That being said, the question banks can be in such a way that even the person sitting next to you, you know, there's no way that you can cheat. Not only the questions are randomized, the answers are randomized too. And additionally, the difficulty of the questions can progress or, you know, how well you've answered. So it does take work on the educator side to think through how to do assessments and evaluations and so on. Obviously, you know, we may not be able to do away with 100% of the cheating, but it has certainly improved, and several new education techniques have come along to ensure that the student he knows what he says he says he does, so, and not just copies from somewhere.
Thank you. Just another question on education. What are some of the impacts you see of AI, artificial intelligence, and robotics on education? And perhaps even more broadly on the church as well.
Arun, do you want to take that question?
So we've reached a point where you could even recognize who's in the video, and we could even reach a point where we know where a person has stopped the video, and then later on provide feedback to the teacher saying that you know, it looks like your students didn't understand this section because, you know, 9 out of 10 students paused your question there. And we don't know what the full impact of AI is going to be, but just that it's become much more accessible and usable. Uh, they have already started using AI for consultation skills. So you would actually have a virtual person who will answer like a regular person, and depending on what you ask them, they will respond accordingly. When we were in the States a few months ago, we saw that in University of Wisconsin, where they were using that to teach their fellows geriatric medicine. They would do that. Now AI can be used for the church side, for connecting with people on social media, and helping guide them through questions they may have. I still think for something like that you'd need a person in the end, but it can certainly help there. And honestly, I don't know what the impact is going to be, or when the world will say we're going to stop it. Like, for example, IBM said they're stopping facial recognition. They're going to stop using that and produce that anymore. But it will certainly have an impact on education, on church, and on our life life as a whole.
Just talking about the church, what are some of the ways in which churches and Christian groups like ours can leverage online technologies for teaching of leadership and other Christian material?
A simple thing would be using it for diagnosis. If you create enough data in a place in Africa, let's say Nigeria, you put in all the symptoms and all the signs and all the physical findings, and for 1,000, 2,000, 5,000 patients, and then if you have AI, then you will be able to predict, given the signs and the symptoms, the diagnosis. And so in a church situation, I would say that non-doctors, non-nurses, just healthcare workers can use that to care and provide help in poorer areas or rural areas.
Thank you, Vinod. Arun, do you want to come back on that question of the way churches and Christian groups like ours can leverage online technologies for teaching, not just in medicine, but in other areas?
Oh, absolutely. We could create content online. We can use different language translations. We can do transcription. We can have live seminars like this. We could have like our new international family medicine course that we've launched. And we can do this in collaboration with organizations all over. And additionally, we can help with tech infrastructure for people who want to teach in different areas of the world and different languages. And then we could, further get like we talk about the panel of experts. Now there's no limitation. We could invite people who are experts from all over the world in different fields to come alongside us. And we've already started the training website. There's a lot more we could do there. There's a lot of education tech. You can do self-registration for people to connect and then choose what they want to learn. And at the end of it, if we're able to do some assessment and provide a certification, it may go a long way. So there's tremendous opportunity. There's tremendous opportunities.
Thank you very much. Question from Howard Lyons now. Given the importance of internet connectivity for distance learning, how are you considering partnering with providers of low-cost internet provision, such as low-orbit loon technology? So Howard is there referring to this new project from the Alphabet Foundation, which involves putting big like weather balloons 20 kilometers above the Earth's surface to provide very good, fast 4G and cheap connections. Now, I think in India, your internet connectivity is very good already. in rural areas, but there are parts of the world where it's still very, very poor and where internet connections are going to be the main
Right.
limitation. So any comments on those kind of partnerships, Arun?
Yes, we are actually facing some of those internet connection issues, not for our doctors courses, but for our community health lay leaders program that we have. So we actually have a lot of workers in rural areas, and they only have intermittent connections. So they don't have connection all the time. So there is new technology available called XAPI, where they need to only be connected intermittently. They can download the learning material to their local devices, and then only when they connect back will reports go back on there. We in India have 4G now is prevalent in pretty much every second tier city, and it's getting there. But we have not considered something like the weather balloon or of that sort. But I don't see why it would be an issue. Essentially, if you have connectivity to make a WhatsApp call, you could do online teaching. So it's just that basic requirement. And if you think about online teaching as mostly asynchronous, where you don't have to be all the time, you don't have many periods of time where you have to be connected, then that actually allows for more learning. So maybe the student downloads it, finishes at his convenience, and then comes back. So we have to think of different models where it's not on a tight schedule, but it's on what you've completed that you progress within a learning format.
Thanks, Sarah. A question now for you, Vinod. This is from Anne Biro, who's the director of Nurses Christian Fellowship International, which is a partner organization to ICMDA. And Anne is asking about home-based care. Vinod, what do you see as the potential for the church being part of home-based care going into the future?
A good question. Actually, what we have done in this company is to recruit people who were missionaries or who had interest in evangelism or church planting. So what I tell people is it is easier to get people from people who are Christians and train them in health than to get people who are trained in health for them to do actually mission is more difficult. So I think the church can produce a lot of healthcare workers who would be needed, and they should be encouraged to get involved in home-based care.
But a follow-up question from that, perhaps for Arun, if people are illiterate, can they access these kind of systems that we're talking about? I guess some of your lay leaders training might be in that context.
Yeah, we've been teaching lay leaders who are only in less than 8th grade pass, and actually lately we've taken up another project for COVID care management for lay people, and these in India they're called ASHA workers who have really basic education. So here the tack we are taking is a lot of videos, short videos, animations, which explain simply with a diagram and not too much of writing there at all. And then we're trying to provide in various different languages. So that is one of the things that we've been doing. So we have successfully trained, like I mentioned earlier, community health workers who have just eighth grade pass or less, and in India that is a huge thing for places where there is no one to even provide basic medical education. But we've kept that to very basic things, nothing to do with medication or a diagnosis and all of that. But we've left that only for health education. Basic things like cleanliness, washing hands, and identifying maybe if fever has been there for over a certain amount of time, then it might be a good idea to go to the mission hospital. So that sort of training we have done, and in India we've been running that in 4 different languages, and hopefully we'll be able to provide some of the learning material for other countries too in the near future.
Just to add to that, Peter, your question was about illiterate healthcare workers or illiterate patients?
Well, I think it could apply to both.
Okay, now if you have an illiterate patient, of which we have many, and it is not simply about being illiterate, old people are sort of technologically illiterate. And so we have a group that cannot navigate through technology. They may not even have seen a smartphone. Sometimes they have an ordinary phone, but they don't have a smartphone. And so this is another important reason why you have a healthcare worker who becomes the advocate between a doctor and the patient, especially an illiterate patient or an old patient.
Okay, thank you. Next question. You've raised the possibility of having a whole global, worldwide registry of Christian doctors who could provide support or diagnostic facility or all sorts of things. It's a wonderful vision. How might it be possible financially? Because that sort of thing would need presumably a lot of investment, which would be beyond the capacity of most faith-based organizations. Can you, do you have any thoughts on addressing those capital shortcomings?
I just want to say that it will not at all be expensive, but I'll allow Arun to answer that question.
Yeah. So if you think about that, it will probably be 2 things. One would just be a registry where it wouldn't require much to put a registry online, where we could probably already have our ICMDA members because they're already verified and membership. We can list them as possible providers there, and we could ask them if they're providing what sort of care. Are they providing general practice? Are they providing hospital? Are they providing telehealth? Are they providing home-based care? And we could provide a quick way to people in the area or elsewhere to search for them, and that will essentially be like a yellow book for doctors associated with ICMD or the Christian network. Then the other level beyond that would be actually providing telemedicine. Now that would mean having a server or having multiple servers in the cloud where you would make the virtual connection between a doctor and a doctor or a doctor and a patient. Now that is where you would need some investment upfront. And even that is a pay-as-you-go model. So it's an upfront investment is not much. Software available as open source doesn't cost anything, but it will require some cloud server space and 1 or 2 technical experts to get it started. And the advantage of going with something like that is scalability is massive. And if there is some sort of revenue sharing that can occur, so the capex investment won't be much. We'll have to worry more about the sustainability. How do we continue to do that? So those are my few thoughts. I certainly think it is a feasible idea, and being worldwide, we can utilize resources in places, the technical know-how and the administrative skills. We can hire from anywhere in the world. So that will further reduce costs and also allow for easy access for patients or other doctors who are searching for help.
Thank you very much, Arun. So we've been listening to Vinod Shah and Arun Zechariah from CMC Vellore Hospital in India, talking about the way that the COVID pandemic is going to impact on healthcare in the future. And it is said that it is extremely difficult to prophesy, particularly with regard to the future. But I think you've both done an incredible job in opening our eyes up and helping us to see that this crisis is a chance to grasp the many opportunities that are there and to adapt for the world in which we're going to find ourselves very shortly indeed. So wonderful overview of medical education, patient management, healthcare delivery mechanisms, and how they're going to be affected in the future. And just remains to me once again to thank Arun and Vinod so much for your time and expertise today, and opening our eyes up to the opportunities of the future in a way that really doesn't frighten us, but gives us great hope and encouragement to grasp them. So God bless you all. We'll see you again shortly on ICMDA webinars. Thank you.